And so we go on now, and we are entering the session of stents and balloon. And Ajay, you are there. You are supposed to chair this session. Ajay was, no, you guys keep sitting. Not okay, Rajiv, you can leave. You have been there for a while. Ajay is not there, so we just carry on. He was there. All right, so we are coming to, I know it's quite late in the day, so deliberately we kept some videos by our team, so we'll try to discuss as many as we can, and rest we will see maybe in the next meeting then, all right? So 38-year-old female patient with grade 3 SAH, and this is the aneurysm, all right? It's a very broad neck ACOM aneurysm. Let us show the other angles as well. It was multilobulated. Here you can see there's a lobule near the neck. I think, Vincent showed a case of an intracircular device with near the neck. This is the anatomy. This is like almost the down the barrel view. You can see the aneurysm is really involving the ACOM complex. So what to do? Will we do balloon-assisted coiling, double balloon, stent, FD, 1 stent, 2 stents? Let me show the picture again. This is the one angle, and this is the other one. Anyway, let's carry on. So, Vincent, you do. Can you show me just the... Again, let me go back. Yeah. This is the bifurcation.
Ruptured?
Yeah?
It is ruptured?
Yeah, this is ruptured. And this is the...
We'll try with balloon and coil, yes.
Yeah. In fact, when I looked at it now, I thought, okay, we can balloon and coil. and this is the other plane. There was near the neck lobule as well. And we decided to do stent-assisted coiling in these cases. Some of these cases, we know they will not come back for follow-up in our circumstances. So sometimes, if the bleed is not too bad, it will not need a shunt. And I'm pretty comfortable. Stents in acute SH, FD is a different matter altogether. And so we went ahead with stent-assisted coiling because we had to be sure we get all those irregular lobules. With balloon, if I stop and can't get the lobules, there's some filling, then we are really stuck with it, what to do. So again, we always take triaxial. This is one plane. Here you can see what we are trying to do, multiple irregular lobules. So I was worried that if some residual filling, stent should take care, and there was near the neck lobule as well. So we thought maybe stent will be a safer choice here, or at least a long-term a practical choice here. And so what we do usually, we use a single stent, but we use sort of shelving technique to open it up. And that's the coiling micro. I think it was phenom in this patient. In the other plane, we like to see 2 planes that is trying to point in the center of the aneurysm so that we can use long first coil. And sometimes, if not form a loop, we withdraw the microcatheter, form a loop, and then push the microcatheter in. And that's I think we are using baby Leo. We always force some coil loops in so that if the microcatheter moves, coiling microcatheter moves during stent delivery, it doesn't rupture. So we always like to get, and we want to use a long first coil to form a great cage. I think that is very important in these patients. And when we come here, this is where we push the both stent microcatheter to expand the stent a lot, as you can see it here. And so we have pushed the micro, and suddenly you can see the stent overexpanded there. And that is very important to really what we call a shelving technique. But when you are doing this, your guiding should be very stable. So under your junior or your other hand should be on guiding, pushing it forward. That's the only way you can build up force to overexpand the stent in that area, so that we can try to cover most of the neck by a single device. So now you can see we have created a surface where we have got a good, nice first coil which is hugging all the walls, which is very important. Long first coil to us is becoming very important. 2 views hugging the walls, otherwise one is in trouble. And you can see we use multiple small coils. They are going to different lobules. We keep increasing the pressure, decreasing, and enter all those lobules. To us, that is very important rupture. We didn't know from which lobule it had ruptured. So we try to coil. As there's some coil coming there, overlapping the stent, doesn't matter. That is where stent is open. So we have re-entered the lower part now. So this is what we do with stent. Sometimes we reshape micro, resheath, enter different parts. And we try to coil the various parts, at least some coils into these lobules for sure, before we stop. And in the other plane, we can see still there is some filling of 2 of these lobules, and then we try more coils at the base to pack it tight. And that was the reason I used a stent, because I wasn't sure with the balloon I'll be able to get it that hard, and I wanted some progressive thrombosis after the procedure. And now there is some stasis in that lobule. We withdrew the microcatheter, finished the deployment. As usual, we are loaded with Pasugrel preoperatively. Some filling of the aneurysm at the base, but we were hopeful as the heparin will go off, it will thrombose further. If these lobules were not there, maybe it would have been balloon and coil. Okay? That was my worry here. Because of those, we thought, and near the neck lobule, we thought maybe stent will be a better choice. As you can see, the drain was already in such cases, so that there is no issue of CSF drainage. All the vessels well filling. But so what do we see in this image? Even in spite of Pasugrel, what we are seeing, something small clot formation, and this was surprising. Usually we don't get it. Maybe shelving compressed the stent a lot, becoming like a mini flow diverter in that area. Usually we don't see, we do shelving technique a lot, but we know acute SCH is thrombogenic situation. And that's the reason I would absolutely hate to use a flow diverter in acute SCH and a bifurcation aneurysm in acute situation, even with stent. But there was no flow change, no change. We gave some injectable agents. We did a check angiogram next day as well. The small clot remained, but no flow change, no issues, and we just let it be. But you can see next day, the lobules have by and large thrombosed, and we were quite comfortable about it. Again, as usual, we extubate with controlled blood pressure in this, and we continue with our antiplatelet agents. So we love to do balloons. I mean, maybe 90–95% of aneurysms in our acute SCH we do with balloons, but in specific situation where I could coil this aneurysm with balloon, but I was worried about the small lobules which were near the base, and if I don't get coils in, then I was worried that whether we'll be stuck with it. One may argue, but here we are loaded with antiplatelets, so I mean, maybe it would have worked, and we opted for stent. But we saw in acute situation, even with antiplatelets, sometimes you can get clot formation and issues. And even with stent, it's just not place a stent and coil. We have to reposition the micro to try to get different parts of the aneurysm here, and ultimately it was fine. Although there was clot formation, but patient remained well. So
double balloon was option?
Double balloon was absolutely an option. I mean, I can't say no to it. We have done double balloons in the past, and it's an option. But as I said, in this case, the lobules were near the base, and I was looking at progressive thrombosis. Whether it was the right choice, I don't know. If clinically there was a complication of this clot formation, I would have said, come on, in the past I would have done with a balloon, and I would have done with a balloon. So it's up for debate. We don't know the right answer. I mean, Vincent,
what we know is that if you need truly during the rupture case to use a stent, it's doable. The safety is there, especially if you have no ventricular shunt. I mean, the literature, it's reported that the safety is pretty high, especially if you know to monitor the antiplatelet therapy again. So the key of this is having the tool to perfectly monitor the platelet inhibition rate. That's why here, typically in this case, we are doing it. I have cases I've showed during the course here, but I cannot show it again. But where it's really dysplasic, we go for stent and coil, despite there is a grade 4 with an hematoma in the Sylvian fissure. And we just use the cangrelor, monitoring the PY12 inhibitor rate up to 50%, so not 100%. And then we do the stent and coil with a brain hematoma in the patient.
Yeah, so we don't have waste. Most of our hospitals, I don't know any hospital really reliably doing platelet function testing in these patients. So we are just loading and doing them.
Yeah, but this is the future. You will have it, I'm sure, because we need to master the pharmacology very well. And what do we need to control the platelet function? So at one point, I'm sure it will be everywhere. So we should demand for it. We should demand for tight control of platelet aggregation. It's a very good example.
Yeah, I absolutely agree. And as I said, this case was meant to show number one, shelving technique. Number one, as we discussed yesterday in the slice program, sometimes near the neck lobules. Okay, we may argue in acute assess whether we should have done it near the neck lobules. Maybe if you can't coil them, just a stent placement, British stent may be useful. Balloon remains the primary choice in our hands. We don't use that of saccular device, primary, but sometimes when they're near the neck, this aneurysm was very irregular and you are not sure you will get it. Maybe stent-assisted coiling, but stent-assisted coiling, you have to pack it very hard. Like I showed you, we use new roadmaps, blank roadmap to see where the coil is going, and it's just not placing the coils and relying on, we try to pack it as much as possible. We even reposition the microcatheter to pack the whole base very, very hard to be sure. And lastly, whatever you may do, thromboembolic complications are more in acute condition, rather than a simple thing. So you have to be very, and look for the clot formation even in these kind of cases very well. Coming to another acute situation, let us come to this. This is a 44-year-old female and acute subarachnoid hemorrhage, and that's the aneurysm. What do you say? You remember you showed in slice and you placed a flow diverter from A1 to A2? Remember? You had irregular ACOM aneurysm like this, so.
I think the problem, yes, in slice it was different. The case was a little bit different. But the problem we know if we post a flow diverter A1, A2 is that you have a contralateral A1, A2 and it's exactly in the middle. So you may expect the flow still going into the aneurysms
yes.
if you check the right.
Yes.
So yes, it's not exactly the same case.
Yeah, you're right. That had a much wider ACOM, and here it looks when on left A1, the jet of the blood will go into this ACOM aneurysm. So Ajay, since you are fresh after your tea and coffee, we expect a more vibrant answer from you
right
while
now.
we are tired.
So the options are not very much like from left, the right A1 to the left A2 stent and then coil the aneurysm.
Perfect.
Yeah, stent assisted coiling.
Thank you.
Across.
We will do what you say. All right? Yeah. So anyway, we did what the problem is how to catheterize this aneurysm, and there is nothing there. You place the micro, there is nothing left. So what we call is, we never try to catheterize such aneurysms when very, very small. This is a blister-like, but to me it's a sacral aneurysm. It's a classical location. Again, a thick clot, hydrocephalus, so you have to get a drain in before you want to do. You want to have your neurosurgical consultation before in, so we got a EVD done. We keep the drain on a little bit so it doesn't get blocked off by blood, and then we go ahead with the procedure. So you do a bilateral puncture in these patients because otherwise, so what I do in these cases is the coiling micro, I will take into the right A1. I don't try to catheterize. It can jump around, rupture or everything. And that's the stent micro I took into the left A2 as Ajay suggested just now. And then the coiling, I think, now this is the coiling micro which we have taken into the right A1. So I've never tried to catheterize this aneurysm. So we have done quite a few of such cases. So then we have deployed a baby Leo, and once we have deployed it partially, I drop it down. Okay, so this is another plane. So what we do is we deploy the stent partially, it's partially open at the neck of the aneurysm, and we drop that microcatheter over the stent. So we never catheterizing. Once it drop over the stent, it is pointing into the aneurysm. So from that is where we deploy the coil. So just to show you from the other plane, see we are withdrawing it and let it drop over the stent there. And then we take a new roadmap, because always you can imagine with the stent, everything, even a millimeter change in the position of the artery, you may rupture. So we are very open to changing a new roadmap. So we are very, very sure where exactly a microcatheter is. And then we try to place a very small coil. See, I'm trying to place a small coil, but it wasn't going in. And then we managed to push it in. And this is the other plane. So from outside, maybe this was 1.5 into 2, I don't exactly remember. From outside the aneurysm, very, very slowly, you try to place in a partially open stent a coil. And we let and reduce the tension of the microcatheter, let it come back if it has to. it's okay. Even a small coil tip projects, we are very comfortable. It's okay. Stent will sort of push it against the wall of the aneurysm. You can see microcatheter is out of the aneurysm, it's just around the stent. I had a difficulty putting the last part in, I let it be there. You take a run, and in these cases, as Vincent was discussing yesterday, we were discussing, you don't want to pack these aneurysms tight. We just want some loops there to promote thrombosis. Even a British stent is like a flow diverter in a small vessel. And then we detach the coil, bring it out, and then we finish the deployment of a stent. So you can see the coil tip is a bit out, it's okay. Rather than trying to push it in and rupturing the aneurysm can be more tricky, and then it's fine. So these are blister-like, but they're not blister aneurysms. To us, in acute SH condition, flow diverter is not an option. And one can do this technique, and what we call as microcatheter resting over the stent technique to coil very, very small aneurysms. Take your time. You can see some coil tip is here in the ACOM, but the stent is pushing it against the wall. It doesn't matter. Small coil tips like this. There's some residual filling there. It doesn't matter. They almost never bleed again. As the heparin goes off, again you extubate them with very controlled blood pressure. That is very important. You don't want the spike happening at the time of the extubation, and then we let them be. All right, so at least we haven't caused flow change. We have a patency of the ACOM region, which is very useful if this patient goes into vasospasm. So even very small bifurcation, blister-like, they are not blister aneurysms. I still feel, okay, this is slightly more, cumbersome than doing a flow diverter placement, but probably these are the right solution for these patients. And even in the era of flow diverters, we have to be comfortable with stent-assisted coiling in this situation. So Yatilochan.
One stent is there. Can you please other balloon in other branch, because coiling is definitely a risky job. So can you place one stent and
okay, left A1 I thought was too small to place a balloon. Yeah. And even if you place a coil there was such a broad neck thing, I think coil could have run away.
But just to prevent the rupture, or to backup plan is a rupture, because placing the coil is
okay,
really
you know
risky.
what? Yeah. You are absolutely right. Okay, 15, 20 years back, I have placed coils. All right, I even placed a 2-in-1 GDC coil, broken them, but come on, it was, I can't do it anymore in spite of everything. And this is too small, and it was like a pyramid there. Coil stability would have been very, very, you saw, even this 1.5 × 2 coil wouldn't go in completely. I've left the tip hanging out, but with the stent, I'm opposing to the wall. And there is always a residual filling. With stent, I'm comfortable, it will go away. But stent is not changing the flow dynamics, it's quite safe. And stented segment will not even go into vasospasm. So yes, long time back, when we didn't have great stents, I have tried to place coils in these, and I did. But in the current era, I would use a stent.
Here, in addition, the aneurysms is very small, is looking up. And we know risk factor for peroperative rupture is small aneurysms and balloon-assisted. So I think the risk of a balloon-assisted attempt would have been quite high. The flow diverter is 8% complication in A1, A2, and here, to my mind, it's not a good option because the aneurysm is not an A1, A2, it's on the ACOM completely. So it's not sure that it has solved the problem. So I think what you did is very good. And what is interesting is that it allows you to accept to have coil in the artery. So that I think is very smart, because you are not in the obligation to finish the coil, where the last loop it's the last loop that is perforating the aneurysms. The last push, when the pusher arrives and the coil is a little bit more straight than the first loop that are very soft. So that's extremely good. I think the way you did it.
So in these cases, we deploy a coil very slowly. You can take a couple of minutes. Every time you're trying to get a feel, if you reduce the tension microcatheter too much, everything will come back. But if you keep too much tension, you may rupture. So you deploy a little bit, get a feel of it, breathe easy, then deploy a bit more, breathe easy. And when you know you've got some loops there, a tip coming out, and with a stent there is not a problem. At that stage, I was comfortable microcatheter backing out. Another important point is be sure you have detached the coil before trying to withdraw. Last thing is, it has not detached and you try to withdraw, it comes out, it detaches there, you are in big time trouble. So in these cases, like in India, sometimes we use previously used detachment system, I don't care. I use a new one, I detach it 2-3 times. I'm absolutely sure it has detached, and then only I pull out the pusher. So that is another important point. Last thing you want is coming it out. So we take care of the detachment. So each step we take a time. Each step you take a time. You place the microcatheter there, withdraw, you take a run. Is it pointing there, not pointing there? Is all right? Do we need to shape the micro? So I kept the microcatheter a bit shaped. Sometimes we give it a reverse shape to make it point there. Partially deployed stent, and take your time and deploy the coil over a few minutes. It's all right. It's not just pushing it in, so that you're very sure about the feel of the coil, the way it's going. Okay. Of course, biplane is very useful to see whether in 2 planes the coil is going into the aneurysm or not. But I guess I've done in the past in single plane as well. But yes, biplane is very, high resolution imaging is very useful. Take a new road map is very useful. Let a tip hanging out is very useful. It's all right. Okay.
So, but Vipul sir, if the aneurysm were even smaller, which we encounter many a times, and anatomy is like this, then how to go about? Because this is a
Then I would just
very difficult situation.
If
And
it is even smaller, I will just deploy the stent and let it be. Maybe
stent
you
or
can-
flow diverter?
No, you see, I wouldn't like to trap the right A2 in acute stage with a flow diverter. All right.
Yes.
Maybe I can use LV Zevo. Maybe it will have a little bit more flow diverter effect than even than Babylio.
Okay.
It has got smaller holes, right? More wires. Use something like that.
Yeah.
If in any situation you do end up using a flow diverter, I will oversize the flow diverter.
Yeah.
There are situations where we use flow diverter in acute stage, then we oversize it, so you're converting into something in between a stent and a flow diverter, so that you don't cause, because this is acute SH, right? There may be vasospasm. What patient may tolerate in your procedure may not tolerate after 5 days.
But this kind of anatomy is very much common in our practice, and
So
whenever
that's-
it comes, it
then
is
even maybe just
difficult.
placing us even smaller than this, just maybe a stent will suffice. That's it, no coil. Maybe, you know. Okay, let's go on to some another situation, which is all right. Let us go over this case. Let us go ahead. It's a longish video, I think. All right, another patient, 66-year-old, had multiple aneurysms actually. She had a ACOM and bilateral MCA. We had treated the ACOM aneurysm before. We thought most likely distal ACA1, that was most likely the rupture, but we were not sure. And right MCA was also treated with flow diverter assisted coiling in this patient, and this is the left MCA aneurysm. And we'll just show you the picture. This is the 2D picture, and this is the 3D. Now, something like this. You see in this angle, I mean, more of lower divisional, very broad-based, very sessile. Let us show you in other angles as well. How does it look like? Something like this. So, how to treat? Ajay, we are all tired. You are fresh.
This is ruptured, not ruptured.
There was a diffuse bleed. Truthfully, I felt most likely the distal AC had ruptured, but it was diffuse blood. So we had to treat all 3, but we staged it. We didn't treat it. She had come in late evening, and that evening we just went and coiled the distal AC aneurysm. But I wasn't sure that this hasn't bled. I couldn't say because blood was everywhere.
There was no acute bleed, no, of this one. The
By
bleed
the time,
was
I
in the
think-
previous
I don't know, by
setting.
the time we treated it, it was like a week or 10 days after the bleed, all right? But we decided that since there's a small probability this one has bled, so we just went ahead with this one also, right?
Yeah.
But at late night, late evening when she had come, we just treated the distal AC, as you can see, because to me that explained the clot there and bilateral bleed, not the MCS, but yeah.
So either
So let us treat it this unruptured.
either Y stenting and coiling, or single stent and just jack that stent against the neck
Shelving
in
the
the
single stent.
shelving of the stent in the inferior division and the coiling.
Dr. Rahul is there. He's a keen neurosurgeon.
Or you can have nowadays you can have contour plus stent. That
All
can
right.
also be.
Rahul. And then we come to contour and stent.
Definitely, as you said, as everybody said, that Vipul also said that clipping has to be compared with the coiling method. Definitely, clipping is straightforward in this case, very straightforward. But if you want to go
Okay, so, Rahul, now look at this view. This is almost like down the barrel view. And I will show that later on as well. 1 second, sorry. All right, something like this. Now, in this angle, Rahul, if you see, the aneurysm is almost like it's involving the whole circumference of the MC, or at least 80% circumference. So by clipping, can you reconstruct it completely?
Yeah, definitely we can reconstruct it, because if it is an unruptured one, there are not so much of adhesions. We can block the MCA for some time, and we can even put multiple clips. So this can be very nicely reconstructed.
Yeah, I've seen a lot of my colleagues, Rahul is also very experienced, they do reconstruct these aneurysms. We should know that option. Of course, since we are discussing, I didn't do that, but still it's an option. And Vincent, how would you treat this one?
For me, it would be an oversized atlas plus coil in the inferior branch. When you oversize the atlas to 4 mm, 4.5, it's just an unsheath maneuver, and you have the complete, so you can protect 2 branches with just a simple maneuver, and then you just coil.
All right, so yeah, I thought about that, a single stent, whether atlas or anything else, but I was just worried, it is so shallow. Once I've deployed a stent, how many coils will I be able to place in it?
Okay, you do in simulation, you size the atlas, and you see the size that is allowing you to have enough closing of the neck at or against the superior branch. It's very easy to do. Just have, yeah.
All right, that's a very
it's not a difficult aneurysm in my view with 1 stent and coil. I don't think so.
All right. And here you can see this is the down the barrel view as we like to create, and we were discussing in the slides course as well. This tells us what all is involved and what all we want to coil or how we want to reconstruct. So we decided to use a baby Leo, but I was not sure I will be able to get a complete packing in. So we decided to use a balloon in the upper branch as well, what we call as the hybrid technique. So that I didn't want to shelf it initially. I wanted to partially deploy it so that I can get a coil into all parts of the aneurysm. That was my worry. If I shelf it, it's too shallow. There will not be enough space for good coiling. Atlas is a great stent, and we have seen a lot of progressive thrombosis with Atlas as well, and changes the angle as well. So we use an Eclipse 12 in the upper branch. I think we use Synchro and Headway for delivery of the stent. I think now, so this was the strategy, partially deployed stent here, balloon here, so we can get a dense packing in and we can reconstruct. Having a partially deployed stent also means that I can reposition the micro, which to me becomes very important in such a shallow aneurysm, if need be, and in the end, complete the deployment like this, which is what I think Vincent meant by Atlas. Atlas will come on like this anyway, by itself, yeah. But I just wanted to be sure I get the coiling part done, and I end like this, so, yeah. So this is what we did. So here we use 2 axes. We want to have 3 systems in, because one guiding we really want high up to deliver the stent properly. All right. This was a working projection in one plane. So we just place, I think, balloon in the upper branch. Let me see if I can make it slightly faster. Eclipse 12. And we, as I mentioned, we use this kind of pigtail shape on this synchro a lot to catheterize arteries coming at an angle at a bifurcation. We found this inferior lobule. He gave it a perpendicular shape in this case, and just with a gentle wire massage, we move in 2 planes. We are looking at which lobule we are entering, and we started to do that one first. All right. If you see, I haven't even inflated the balloon. It doesn't matter. We only inflate the balloon when we need to. Otherwise, play around. From the lobule, the coils are coming a little bit into the base. Let us see what did we do then. And okay, we take run. Are we comfortable with this? We are comfortable with this, I guess. We are calling that inferiorly pointing lobule, as we called it in our head. So I will sit with my tech, make all those angles, right? This is the angle for this, this is the angle for this. You do a lot of preparation before you move in. And then, of course, as I said, we were very fond of this, at least in the flip system. The blank roadmap shows where the coils are going very, very well, where the microgather tip is. And even balloon, when we inflate, you can see partial inflation. You don't need a dense balloon inflation. Now, once we have done this, we thought anterior lobule, as we call, we gave it a J shape. I think the eye points to that, what we call is the anterior lobule, and we reshaped a micro, and then we entered that part. And from the base itself, we started coiling that part. So it's peacefully done. You take your time. And as you start coiling, we increase the heparin a bit. A major issue in these cases, acute SH. And then, For this lobule, we took a reverse shape microcatheter. We shaped it like this so that it points up. We don't have to catheterize, so we don't have to use a wire there. And then see, it is pointing by itself with this reverse shape. It is pointing by itself there. We take out the wire, and then coil was going here, so we can inflate the balloon a shade, and with some loops also you can catheterize. And then, if need be, we can inflate the balloon. So you see, we have created the neck. Once you have coiled this much, the neck of this lobule has become actually smaller. Again, a partial inflation, soft inflation of the balloon, so that still microcatheter can move around. These are ruptured aneurysm. You don't want to have a very strong inflation there. And again, you start coiling these part. One coil, and then one coil is in, then some small coils at the base. Again, you can see at the base now, the base we are coiling among all this coil mesh. It's very important to have a feel of the coil, that you're not pushing the coil against too much resistance in this small ruptured aneurysm. And so we managed to get all the 3 lobules. So then you take different angiogram, different angles, they're truly thrombosed or not. The challenge why they're truly thrombosed or not, because one of the issues is, if there's partial filling left, and when you do such packing in small arteries, thromboembolism can happen. Then you want to give injectable antiplatelet agents. If there's some filling left and you give injectable, then it becomes a dangerous situation. You know, you will not have progressive thrombosis. You may actually recanalize the aneurysm a bit. So we really like to be sure that all the lobules are thrombosed. So we know if you have to give more drug and heparin, now it's safe. So at this stage, we just increase the heparin because we want to avoid the antiplatelet agents if possible. So in aneurysms, our heparin level, we keep increasing. At this stage, we want our ACT more than 250 for sure. Of course, we check all the vessels. And then when you do such coiling in small arteries, we watch them for half an hour for any clot formation. And still, in front of no clot formation, they can form clot, small artery, very broad neck aneurysm. So we did give aspirin to this patient post-operatively to prevent thromboembolic problems and carry on. So as I said, balloon-assisted coiling is a very powerful technique. We love it in acute subarachnoid hemorrhage. One has to, as Professor Vincent mentioned, where each lobule, how you're going to shape, how you're going to point. We like to catheterize them without wire in all these small aneurysm patients. Balloon need not be always be overinflated. It's partial inflation, no inflation. All of this is important. And we change our micro. You don't use the same micro because they lose their integrity. Be open to using a new micro catheter to get a perfect shape in. Like we use a simple J, we use perpendicular shape and reverse shape for the 3 lobules in this patient.
Yeah. So in this case, the magic was not only the balloon, but the different shape and yogasana of your microcatheter, different yogasana, I'm saying, different shapes.
Yes.
So that was impressive. Those
as you say,
hyper shapes.
Yeah, I just wanted to show to a lot of youngsters that balloon coiling is good, but we have to shape the micro. We need not catheterize the wire in acutely ruptured small aneurysms, and with multiple shape we can catheterize them. And if you are patient, even broad neck aneurysms, you can coil, keep coiling, and slowly you create a neck. First 2 lobules create a neck for the 3rd lobule, and one can do all of that. So balloon coiling just remain a very, very powerful technique in acute cases. I mean, and that is all the message which we wanted to give.
Yeah, because if the shape is good, the catheter is going to be in the center of the aneurysm, and the coiling will be very much easy, and it is very much stable, we can see.
Can I ask one question? Yeah. Excuse me?
No micro will take 3 shapes and remain fine. So you have to use a new micro in these kind of situations. One may try, but at least 2 micros one would need. Once you have shaped them in perpendicular shape, it will never take a perfect reverse shape. All right? So be open to using a new micro in the procedure when you're reshaping and re-entering. Yeah. How we decide? Okay, suppose look at this aneurysm. If I use, we know any superior pointing ACOM usually it will need reverse shape. Microcatheter will point down, you want it to go up. I can go back to this previous case. So we see from the parent vessel and what angle the aneurysm is rising, right? And in our mind we do. I know some Japanese said they can create 3D models and that itself predict which shape we work in our mind, all right? So we know ACOM superiorly pointing aneurysm will usually need a reverse shape. Inferiorly pointing usually is a J. And eccentric pointing lobule, we give a perpendicular shape. So you look at the parent vessel and angle of the lobule, and then you imagine how the routine microcatheter will go. Sometimes if you are very confused, give J shape, try to catheterize, and once the microcatheter, the way it's pointing towards the aneurysm, you know what secondary shape you need to give. You bring it out, give it that second shape, and then send it in. All right? It's a whole section. We have whole lots of videos showing different shapes of micro how to catheterize. We don't have time for it. But yes, I think shaping is very important. As I said, 95% of cases, we never wire the in ruptured aneurysms. We just use the shape to enter. Only ICA bifurcation aneurysms, you have to wire. A1 ACA posteriorly pointing, you have to wire a bit to catheterize. So there are very few aneurysms in particular location that we need to wire them a bit. Otherwise, most of the aneurysms, you can enter them just by the shape. And build with torque of the Traxxas wire. Traxxas wire is great to give torque. We love headway microcatheter, but they take these complex shapes and remain stable pretty well. Yeah.
So while removing the microcatheter, any threat to the coil mass, which is too much of shaped, bent too much?
What about the coil mass?
While removing the catheter, which is too much shaped.
Okay, that's very important question. Not the shape, but yes, removing the microcants, and these are not as very soft coil, they can pull back the coil loops a bit. So while removing, we always do is we'll inflate the balloon, we'll use the Traxxas wire and clear the tip of the micro and then withdraw it very slowly and usually with balloon inflation. Okay, a Traxxas has 3 centimeter tip. When the dense part is aligned with the proximal marker on the microcatheter, you know the tip is by and large clear, and slowly under balloon inflation will withdraw the microcatheter, because soft coils, loose coils at the base, sometimes loops can come out with the microcatheter. It's an important point which you raised. We always do this. We never withdraw just like that.
So just to add to the taking out of microcatheter, as Dr. Vipul is telling, with the help of Traxxas, the 3 centimeter, what we are doing, we are the last coil pusher wire we are using for that, because pusher wire is also having a marker, 3 centimeter marker, and when that marker is ahead of the 3 centimeter this thing, then your the coil is pushed, and it is
I used to use that, but a long time back it happened that one of the coils, it was detached, but detachment still stuck to the micro. The pusher wire is thin, it still cleared the tip, but the coil detachment was still stuck with the micro and it came out. So we started using a thicker wire for this purpose. So you are right, that's one of the ways to do it.
What we do, like we take at least more than 50% of the pusher wire outside, because many a time there is microfilament which might be in contact of the mechanism, the detachment mechanism. So after taking out 50% at least, then slowly go back with that, because if some microfibril it has come into this microcatheter tip, it can be pushed again.
Yeah, once we had a problem, so we just started using a thicker wire, and the wire will not come out of the micro. So you see, pusher, when you are aligning with the proximal marker of the microcatheter, the pusher wire is outside the microcatheter tip. All right. So, but yes, wire, you are using a stiffer wire. One may say that it is just safer to use the coil pusher for it. But once or twice, in spite of that, we had a problem. So we started using the Traxxas wire we love, just to the tip of the micro and slowly withdraw. But balloon inflation is the key. Keep the balloon inflated in that process. All right.